Hi everyone, my name is Bruce Bassey. I'm an addiction psychiatrist and I'm going to be talking about addiction as a disease. I really like this topic because it gets to the crux of why I went into psychiatry in the first place, which is to get to understand what people are thinking and why they do what they do. I find this to be one of the most fascinating puzzles in clinical medicine. Not only do I have this curiosity about how others think and how the brain works, but patients come to me and their family members come to me just dying to know why this continues to happen. Why does addiction continue to tear the family apart? If you think about it, continued substance use is not a rational thing. It doesn't really make much sense to continue using despite all the harm it's causing. So that idea right there contributes to the mystery of why it continues. Hopefully this lecture could help it feel like less of a mystery, and I hope that for those who have an addiction or are in recovery, I hope they will feel better understood. And for those who are trying to support these folks, the families, hopefully it would feel like there's a lot more hope. The goal is that this discussion could help reduce the stigma against seeking treatment, as it's not a moral failing, and also by understanding the mechanisms of addiction, we can reverse engineer treatment approaches to help figure out ways to stop. Why do we have this argument? Because it continues to carry forward from the past when we didn't really understand much about neuroscience, about memory and reward systems. Prior to understanding the brain, drug use was just considered a moral weakness and a lack of willpower and an unwillingness to stop. If you think about it, if you don't really understand the exact purpose of each part of the brain, you might have this viewpoint. When we think of our experiences in life, we think of it as just one blended, continuous experience. We don't necessarily default to wanting to break down behavior into its component parts and figure out how each part of the brain contributed to that. It just results into one end action. So of course, back in the 1800s, when we knew nothing about the attention, reward, and memory systems in the brain, the Puritans in colonial America just thought of alcohol use as a moral iniquity. Since some people are quitting, therefore the people who don't quit don't have a high enough moral standard, or they're just not willing to stop. So since we don't really know the exact underlying mechanisms about what is perpetuating drug use, people just started to believe that the best form of treatment was to increase the threat of punishment, and therefore drug use became criminalized and stigmatized. Having this conversation is great for the field of addiction psychiatry because it helps educate us and other people who are not very well educated about the disease process of addiction. There's tremendous shame that people have when they use, and they're just looking for something that can lift that shame off their shoulders, understanding that biological underpinning. Gaining that understanding of what's going on beneath the surface can help reduce that shame and have individuals focus more on treatment. But if we're going to have this conversation, it's imperative to talk about the specific details. Saying that all substance use is a disease or is not a disease would be a massive oversimplification of what we're talking about. Not all substance use is a disease, at least when it first starts off. However, after the first initial exposure, all bets are off when some people have a genetic propensity to really enjoy the effects of a particular substance. And when you combine that with particular memories or trauma or emotions, that can lead to uncontrollable use. When first starting off having this discussion about addiction being a disease, it helps to talk about the definition of addiction and the definition of a disease. So the definition of a disease is pretty well accepted. It's a process in which there is a dysfunction of a body part and has subsequent signs and symptoms, and it causes some sort of harm to the body. This definition does not necessarily mean there can't be external influences to the disease process. For example, diabetes is a disease in which there's a dysfunction of the pancreas and also in the way your cells use insulin. Diabetes can be worsened by diet and inactivity, but it doesn't necessarily mean it's not a disease process. Similarly, alcoholism is a brain dysfunction with signs and symptoms of compulsive use and dysregulated value systems, dysregulated executive function. It turns into a disorder of choice. Just because alcoholism can be worsened by certain psychosocial factors doesn't necessarily mean it's no longer a disease process. According to ASAM, the American Society of Addiction Medicine, addiction is a treatable, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. People with addiction engage in behaviors that become compulsive and often continue despite harmful consequences. So it involves a stress-induced, genetically mediated, primary, chronic, and relapsing brain disease of the reward system, memory, motivation, and related circuitry. And it alters motivational hierarchies such that addictive behaviors supplant healthy self-care behaviors. It becomes a compulsive action resulting from an irresistible urge, especially that is against one's conscious wishes. So for those individuals who disagree that addiction is a disease, they often make the choice argument. They say that people can quit, they quit all the time. If you just raise the stakes high enough and punish them enough, raising their motivation to quit, and an addict will eventually change their behavior. This is why they think addiction is not a disease, because the behavior fluctuates depending on one's motivation to stop. So if they're just highly motivated enough, they can just stop using. Thus, they make the argument that not stopping drinking alcohol is an example of a matter of choice, and for those individuals who are not motivated enough or do not care enough to stop. However, this couldn't be farther from the truth. Because alcoholism is compulsive, it is against their conscious wishes. Nobody truly wants to be an alcoholic. It continues despite all the attendant consequences. A patient mentioned to me, he said, "Dr. Bass, I actually don't like drinking. I don't know why I drink, but I'm a slave to it." And this quote captures the irrational component of the process, and it speaks to the disease process of addiction. So all of you who are listening to this came here because you see the problem with addiction and want to fix it. And by definition, you don't want to drink or use a substance, yet it continues to happen. And that right there is the exact definition of a disease process. So ultimately, the argument of choice really comes down to a question of free will. So I believe that we do not actually have as much free will as we think we have, and I'll explain. In order to start inspecting our behaviors, we need to start inspecting the origins of our behaviors, and that comes down to figuring out the origins of our thoughts. The thoughts are the parent of our behavior if you immediately go upstream from your actions. Most of us, we go through life thinking we can make choices. We can choose either Nike or choose Puma. We can have chicken or we can have steak. We think that we're the conscious source of our thoughts and actions. If we feel we want to move, then we move. We think that we're actually the conscious voice in our mind and the author of our life. However, we actually know these assumptions are false. That's because everything that constitutes your will is actually the product of a long chain of prior causes, including your genetic makeup, which you're not responsible for, and your past experiences, which are the cause of randomness, which you're also not responsible for. Some people think, there are people out there who do some really bad things. I choose to not do those bad things because I'm a good person. I could do the bad things, but I don't. I don't want to. In fact, I don't know how they can do such a thing. But if you were actually to put yourself into an addict's shoes, trade places with that person, atom for atom, and inherit all of their experiences from birth onward, you would actually be that person. There'd be no extra part of you that would be able to resist that behavior any better than they would. You would have experienced all of their trauma growing up. You would have experienced all that same loss and setbacks that they have. You would have the person's genes, their experiences, and thus have an identical brain and an identical state of their brain as theirs in the moment that they made the decision to use. So if you truly inherit that person's soul, brain, you would have behaved exactly the same way that they did. So the role that luck plays in this is a decisive factor because you didn't actually choose your genes and you didn't choose these past experiences that are having an impact on your decision making. If you think about free will and the decision to make conscious choice, you would think about your thoughts and you would wonder if you can even control your own thoughts. The problem is that we don't really know what motivates us to make certain choice. Not only do we not know our motivations, we actually don't even understand why we have the thoughts that we have. We actually don't even really have as much control over our thoughts as we think we have. Your thoughts are very much like my words. What are you going to be thinking next? What am I going to say next? I could start wondering about the genetic makeup of alpacas. The same thing kind of happens in the privacy of your own mind. You can't choose your next thought. You don't know what it would be until the next thought appears. We can't actually choose our thoughts before we think them, because that would require that we think them before we think them. As an experiment, if you were to think of any country in the world, you'd ponder for a bit. You end up thinking of a country that you remember had some sort of meaning to you in the recent past. You don't know why you actually chose that country over another country. If you were to explain why you chose that one over the other, you might have a story to tell. Maybe you were in that country or heard of something on the news, but why didn't that have the opposite effect? We don't know for certain why these sorts of things have the impact they do, and our explanations for why we chose what we chose are almost always wrong. We know this from psychological experiments. When you bring somebody into a lab and manipulate their decisions, they will give a story for why they chose something, but they're fairly unaware of how certain other variables played a role in their decision making. We're actually only consciously aware of about 5% of our thoughts. When I first heard that, I was pretty shocked. However, when you think about these few experiments, you'll actually realize that's pretty true. In psychological experiments, they'll bring people in the lab and have them hold a hot cup of water versus a cold cup of water, and you can actually get people to cooperate with you more or like one person more than another, and they have no idea that the temperature of the cup in their hands is actually influencing them. And in fact, the time of day can actually make people more impressionable. There's another experiment where you show somebody a red dot versus a blue dot, and they'll actually rate the same physical sensation as being more painful when they show them a red dot versus the blue dot. They won't actually state that the red dot is causing them to interpret that stimulus as being more painful. It wouldn't be actually in their conscious awareness. There's also marketing research that found that people actually spend more money in a carpeted airport than one is not carpeted. They'll not actually tell you that it's because of the carpet that they had that reason for wanting to buy something that day. Similarly, in a liquor store, people who listen to French music when shopping for wine actually makes them more likely to buy French wine. But if you ask them afterwards, they would not actually say the music had any influence on the decision making. Also, what I find most fascinating about the genetic influence in decision making is the case of twins reared apart, which is twins who have the same genetic makeup. They're identical twins, but they, for whatever reason, were separated at birth and raised in different households. And what you'll find is that there are cases, twins reared apart, where both individuals bite their nails, both smoke the same type of cigarettes, they drive the same type of car. Even there's cases where they vacation at the same exact beach in the same state. They might have the same phobias or same color or smell preferences. So it makes you wonder how much of that decision making, those choices, are made up by a genetic fingerprint, if you will. All of these psychological experiments have convinced me that we're largely unaware of our own thoughts. We're also not only unaware of our own thoughts, we're unaware of the reasons that we make certain behaviors, make certain actions, certain choices as well. So if we want to really inspect why we make certain bad decisions and bad choices regarding substances, we have to really look at what makes up a choice. There can be a lot of different components to a particular choice. So what actually makes up a choice? Well, there's predetermining factors from prior experiences that play a role, and then how we're actually feeling in the present moment that impacts our decision making. Under the topic of genetics, stress reactivity or novelty seeking, that can both be encoded in genetics. Impulsivity and risk taking can be heritable and encoded in our genetics. There's a concept of epigenetics that I'll explain more detail later on, where our parents' exposure actually has an influence on our expression of our certain genes. And our prior exposures to substances actually can turn on and off the expression of particular genes and not actually change our genetic makeup, but have more long-term consequences. There's actually also pretty well-known factors from childhood experiences, such as prior abuse, including physical, sexual, verbal abuse, that can have a role in one's propensity to use substances. Also, substance use in the house. Other prior trauma, such as separation of parents, or other trauma, either physical, emotional, or sexual trauma. There can be memories that are really wrapped up into the memory of one's prior use, and that can be embodied in the perception of that substance. There could be a memory of a particular pain that's alleviated, either emotional or physical pain that's alleviated when people use a substance. And then in the present moment, some people think it's just a spur-of-the-moment decision, but accessibility really matters. When somebody's in a rehab facility, people say that they're obviously not wanting to use a substance because it's not nearby. That really has an impact on their sense of urge to use. And then prompts and cues, billboards, other advertisements. There can be random images, smells, names of people that may prompt them to use. And what ends up happening is that the valuation system in our brain is really hijacked, where we give much more weight and salience to alcohol than to other items in our life. And then motivation. Motivation is a very small component to what makes up a choice. If you think about motivation, it can have influences or subcomponents of self-motivation, motivations from other people. Context can also influence motivation. And one's mood, too, in terms of dual diagnosis. Facilities, mood disorder is the norm, not the exception. It's very likely that somebody has a coexisting anxiety or depression that could be playing a role in one's urge to use. And people have different levels of risk-taking behaviors or dissatisfaction with life or financial stress that makes them more likely to want to use a substance. So ultimately, substance use is a disorder of choice. And it's not uncommon for there to be disorders of choice. There are actually many other disorders of choice. These are all other disorders of choice. In these disorders, we don't necessarily blame the individual for making poor choices. It's just part of that disease process. These disorders in which choice is affected, and substance use is not any different, actually. It's not unique in this regard. Adolescents, they can have difficulty with impulsivity, high risk-taking, disinhibition, which gets them into trouble. They could be diagnosed with ADHD. Adults can be diagnosed with ADHD and exhibit poor planning, poor organizing skills. Individuals with what's called frontotemporal dementia can exhibit apathy, amotivation. Individuals with depression are not immune to poor decisions. They can be very despondent and have impaired concentration, be very indecisive. Individuals going through menopause because of the way that estrogen affects an enzyme called COMT, which breaks down dopamine, they can have processing speed disruptions, difficulty initiating and organizing tasks. Also, people who have suffered head injuries, as you'll see in the next few slides, the orbitofrontal cortex actually sits on a rough surface, a rough bone, and when the brain sloshes around in the cerebrospinal fluid, it can disrupt that orbitofrontal circuit. And substance use is no different. It affects the same reward and memory circuits. So individuals with choice disorders, such as the choice disorders I had in the last slide, show dysregulation in certain circuitry. They have genetic underlying propensities to make certain choices, and they also may have had repeated trauma that affects their stress system, and then dysregulated reward system, memory circuits or memory structures in the brain called the hippocampus and amygdala, and then dysregulation in the attention circuits such as the orbitofrontal cortex, the anterior cingulate cortex, and the prefrontal cortex. When talking about a component of choice, you can't neglect to talk about genetic factors. Koob and Nestler had done some phenomenal work in this regard in the addiction world, and also Mark Schuckett showed that there are genetic differences in how people respond to alcohol, and some people actually really like the reaction from alcohol and some people don't. And the people who really like it are at a higher predisposition for developing alcoholism. In this graphic I have on the right here, age 2 on the y-axis just shows the heritability, where 1 is 100% heritable if you're accounting for differences in environmental influences. And you can see here, cocaine, opiates, caffeine have extremely highly heritable features in the 0.6 to 0.7 range. However, all of these others are actually also pretty high too. Then there's a component called epigenetics, which is the factors that alter the expression of DNA. So it doesn't actually involve alterations in the DNA sequence, but you can have both heritable modifications to the gene expression. You can have modifications throughout one's life that affect our gene expression. And these can be as a result of both maternal and paternal stress that affects expression of certain genes. This graphic on the next slide will probably explain it a little bit better. As you can see, when somebody first starts using alcohol, it normally relaxes this chromatin, which relieves anxiety. Has some other effects on neuronal expression too. And then as somebody continues to use, the chromatin actually becomes more condensed. The condensed chromatin actually turns off and on certain expression of certain genes, and this causes anxiety to actually increase. And this perpetuates the addiction cycle. As you can probably imagine, somebody with high anxiety would be more likely to want to drink alcohol. And not only is that high anxiety from psychosocial consequences from the alcohol use, but it can also be from these consequences of this impact of condensing the chromatin more. And then digging deep into the brain circuitry, primarily the dopamine circuitry, which is most impactful on the substance use. The continued use of a substance actually causes disruption in these circuits. So when you look at early use of a substance, it's mainly associated with positive memories and eliminating negative feelings, which are both good things. And this is positively reinforcing. And so with continued use, this reinforces the reward system. The dopamine system is directly implicated in the reward system. And so this is entrenching and strengthening these neural pathways, these reward pathways, to tell us that the substance is actually a good thing because it's giving us positive memories and it's eliminating these negative feelings. And then with ongoing stress, with continued use, like cortisol, it can start to turn off these prefrontal thinking systems. And then when it turns into disordered use, since that substance is now associated with positive memories, the use continues. The desire remains there to continue to want to return to these happy memories despite all these negative consequences. And so that's where it becomes disordered use, when despite these negative consequences, the substance continues to be used. And the goal, people will continue using to try to eliminate these negative emotions that they feel. However, this continues to worsen the original problem. And so these are the main circuits involved in addiction. They mainly communicate with neurotransmitters, one of them being dopamine. There's a lot of different structures here, and you don't need to read all of the specific anatomical structures of the brain, but you can see in blue, this is the binge and intoxication reward system. There's the withdrawal and negative affect or negative feelings memory system. So when people have a withdrawal, they have a very strong memory of that withdrawal and want to use that substance in order to avoid that memory. And then when we think about the period of time in between use, there's a preoccupation or overvalued system where our attention is then turned to the substance in order to regain those positive feelings and eliminate the negative feelings. So our attention system becomes also hijacked. The prefrontal cortex gives rise to our attention. There's a few different circuits in the prefrontal cortex. It's actually in the front part of the brain. The frontal lobe comprises this pink structure. The prefrontal just means before of that. So before or in front of the frontal lobe. Prefrontal cortex is actually in front of the frontal lobe. And there's a few different circuits. The orbitofrontal circuit actually gives rise to giving things value. So somebody who has a stroke in their orbitofrontal cortex can't actually guess the price of consumer goods correctly. And if you can't actually guess the value of certain things, it causes you to put equal weight on most things. And if you lose your ability to value things, you essentially lose your steering mechanism for choice. You start to lose your job, you start to not value your health, not value your family. So essentially the drug has an artificially high value in the brain, and that's because of the orbitofrontal cortex going awry. And then there's other systems called the dorsolateral and ventromedial prefrontal cortex, which give rise to planning and decision making with limited choices. So they involve planning tasks, focusing attention on tasks, inhibiting impulsive responses, weighing consequences for future actions, giving us flexibility of responses or rule shifting, and then also doing reflective decision making. So this gives us capacity to use our past experiences and knowledge to make sense of our current behavior. Without these two circuits, we would lose our ability to plan tasks. Even the smallest things will feel overwhelming, be very difficult to get started on tasks because you don't know where to begin. It will feel like you lack motivation when the center is turned off because the activation energy to actually do a behavior is so high that it feels like you're not motivated. And the last circuit I'm going to mention here in the prefrontal cortex is called the anterior cingulate cortex. And this gives us error evaluation and emotional appraisal. So this helps us evaluate and recognize if we did something wrong. This allows us to pick up on social cues to guide behavior and allows us to see ourselves through someone else's eyes. And for family members who know what this is like, this is a situation where you find someone yelling at someone they love. This can be recalibrated by engaging in fellowship where others can help you see your behavior in a different way. The next really impactful circuit is the reward circuit. As we use a substance, it reinforces and really builds these strong connections in the reward circuits. The main one is the insular cortex, and this gives us emotional awareness and interoceptive representation. So if somebody actually has a stroke here, they'll leave the hospital and forget that they are actually a smoker if they were a smoker beforehand. Interestingly, it also is the place where we attach consciousness to our body. So if you have some sort of visceral state that's associated with an emotional experience, this will give rise to that conscious feeling. So when you have a physical sensation related to withdrawal, there's intense cravings to alleviate that feeling. That's coming from this insular cortex. The nucleus accumbens is the basal part of the forebrain, and dopaminergic neurons originate in what's called the ventral tegmental area and project into the nucleus accumbens, and this gives rise to the positive reinforcement and reinforcement learning. Another area of input to the nucleus accumbens is the hippocampus, and that's associated with our memory system. So in the memory circuits, the two main structures are the hippocampus and the amygdala. And there are areas in the hippocampus which encode our memory and project it to the nucleus accumbens, which is our reward center, so that the better memories that we want to have some sort of reward if we were to get them, and if we're actually driven to getting those memories again. It gives us some sort of salience to our memory. It makes us want to repeat the pleasurable experiences that we remember. The amygdala, which derives its name from Latin from the word almond because of the way it looks, gives rise to our emotions and feelings, which are closely linked to memories. The amygdala sends projections to our hippocampus, so it's connected to the hippocampus, and this makes certain memories more emotionally salient to us. Like I was mentioning, and they're all connected, really, from the amygdala to the hippocampus and the nucleus accumbens. But the amygdala attaches emotions and feelings to this. So when we have a memory of a withdrawal, it becomes really highly emotionally salient. That's also stored in our amygdala. Going through the structures of the brain clearly shows that there's a strong biologic underpinning to the disease process of addiction. And hopefully what I mentioned earlier in the presentation shows that all of these are very closely related. And I think one model that really shows and demonstrates these systems and how they're related is the biopsychosocial model. So if you look at the biologic factors here, such as executive dysfunction in the prefrontal cortex, or any sort of medical conditions involving the brain or blood system or liver system, these can contribute to the disease process of addiction. Sleep can have an impact on the brain circuitry. Poor sleep can cause people to be more impulsive in their decision making. People who are sleep deprived actually buy more calories, buy more calorically dense foods at the grocery store if they're sleep deprived. They also have a little bit more disinhibition. So those prefrontal cortex systems are turned off if you're sleep deprived. Trauma can have an effect on the hypothalamic pituitary axis, and that can have an impact on the addictive process. People's mood, so people who are highly anxious or depressed, these can be triggers to relapse. There are prior memories that are stored in the amygdala and hippocampus that contribute the stress system, which I mentioned. And then the social factors, such as codependence, prompts of the substance and availability of the substance, certain cues or triggers, which can be 95% subconscious, that we don't even really totally understand. The stress of not having stable housing or a stable job or having consistent support system. I put isolation between psych and social overlapping there because there's actually data that shows that isolation as an independent risk factor towards depressive symptoms. So even accounting for all the other variables, being in isolation, not being socially engaged can be a risk factor for relapse and for depression. Each relapse actually is a data point for us. So we can use that data point as a helpful tool for future relapses, because alcoholism is a relapsing, remitting disease, and every relapse is a learning opportunity for us to figure out what went wrong. Each relapse is a helpful data point, like I mentioned, and it helps analyze these factors leading up to the relapse in great detail. Most people would say that they didn't really know what happened prior to that relapse. They just looked at the bottle and they started using. However, this is a missed opportunity if we just write this off as being unexplainable phenomenon. The whole point of understanding addiction as a disease is to help be able to reverse engineer these solutions. So all of these have known influences on relapse rates, but the amount they contribute can vary depending on the person. So I think this is really helpful for us to start to customize treatment plans when we think of the disease process of addiction in a biopsychosocial method. We need to customize the treatment plans depending on your history and where it is that this circuitry went awry. And eventually, we need to address the components of addiction that are contributing most to the process. One problem in treating addiction is that people look solely at motivation, and they try to increase motivation. And this really plays into that original thought process of addiction of thinking about it as not a disease. So if you're only looking at motivation is not going to be the saving grace of treating addiction. The problem with looking at motivation is that it's very fickle. We have big spikes of motivation, which are awesome for doing really hard things just once, such as rescuing your child or sprinting through an airport to catch a flight. But these can come and go. These are waves of motivation that are quite unpredictable. You can have really three sources of motivation: yourself, what you already want. There can be a benefit or punishment that you would receive by doing an action, such as the carrot and stick hypotheses. And then there's also the context, i.e. all your friends are doing it. So you may have conflicting motivations, which are opposing drives related to the same behavior. So conflicting motivations can be a source of psychic pain. You want to eliminate refined sugar from your diet, but you really actually want that chocolate cupcake. So these conflicts can seesaw depending on what's happening around us. So hopefully this convinced you that treating addiction is much more than just increasing motivation. You also have to consider access, cues which can be subconscious, and underlying biologic and psychologic mechanisms. So hopefully when I say that addiction is a disease, it's understood that it's not a license to give up and trying to engage in treatment. You still have that conscious ability to engage in the treatment process. It's not a justification for all behaviors. All behaviors are not disordered behaviors. It's not until you have continued use despite harm and compulsive use that it becomes disordered behavior. I do think that despite not having as much free will as we think we have, we can actually still turn our ship in the right direction. Addiction is a disease, but it's a treatable disease. And I think that's important to remember when going through this process, giving one some hope and understanding that there are real underlying biologic, psychologic mechanisms that explain the disorder of choice known as addiction.